Hello and welcome to another edition of the Osteopathic Lyceum podcast. Today I'm going to actually go through a research paper. So it's not a study, it's a research paper. It's a meta-analysis. I'll give you the title of this one. It's a systematic review, essentially a form of meta-analysis. So the title is Visceral Osteopathy Therapy Effective? A Systematic Review and Meta-Analysis. This was printed or put up for publication on July 17th, 2024 in the International Journal of Osteopathic Medicine. So there have been more than one meta-analysis. So I don't know if it was a scoping review before, or scoping reviews, or systematic reviews. They are mildly different as far as their methodologies. So I don't necessarily know which ones they were before, but generally speaking, all meta-analyses that I've seen of visceral osteopathy and cranial osteopathy essentially say that they have little to no clinical efficacy. That is much more related to the measurements that are being taken and the claims that are being made. So when visceral osteopathy or cranial osteopathy say that they do thing A or thing B, maybe they do, maybe they don't. But actually, let me say that more clearly. When cranial or visceral osteopathy say they do specific things, when you assess that through research, you find that they do not do the things that they say they do. That's the accurate way to say it. Anyways, I'm going to read through the abstract of this. I haven't even read the abstract. I don't have access to the full paper, which is totally fine because I'm admitting that I'm reading the abstract. So there's stuff that I can't pick at in the paper with respect to how they did their systematic review, but that's of a somewhat lower consequence under the circumstances because there's a general arc of evidence here that would allow us to come to a fairly reasonable conclusion and possibly change our approach, or just say maybe we should quit this. So the abstract, to read, the objective. The aim of the systematic review with meta-analysis aims to evaluate the clinical effectiveness of visceral osteopathy in musculoskeletal and non-musculoskeletal disorders. So, to be clear, you have to understand that they're looking at defined disorders and the impact of visceral osteopathy on them based on specific measurements. So, the methods to read. 2 independent reviewers searched PubMed Physiotherapy Evidence Database, Cochrane Library, Scopus, and Web of Science databases in November 2023 and extracted data for randomized controls trials evaluating the clinical effectiveness of VO. The risk of bias and certainty of evidence were assessed using the risk of bias tool 2 and the grade profile, respectively. Meta-analyses were conducted using random effect models using RevMan 5.4 software. So, to look at this, please excuse me, clinical effectiveness. So the term clinical effectiveness is going to have a very specific definition that I don't absolutely have handy with respect to how this research was done, but they have a very clear definition of what they're looking at, what they're looking for, and what criteria it needs to meet to look at this. And then they have what seem like sturdy, reliable tools, the risk of bias tool 2 and the grade profile. Then using the RevMan 5.4 software, that I'm not 100% sure about, but I would have to superficially make the assumption that it does what it says that it does. Anyways, to read again, results. 15 studies were included in the qualitative and 7 in the quantitative synthesis. For musculoskeletal disorders, the qualitative and quantitative synthesis suggested that VO produces no statistically significant changes in any outcome variable for patients with low back pain, neck pain, or urinary incontinence. For non-musculoskeletal conditions, the qualitative synthesis showed that VO was not effective for the treatment of irritable bowel syndrome, breast cancer, and very low-weight preterm infants. Most of the studies were classified as high risk of bias, and the certainty of evidence downgraded to low or very low. Okay, so we get some evidence or some indication of the very specific things that they were looking at. So the musculoskeletal conditions, they were looking at low back pain, neck pain, or urinary incontinence. So there would be tools to assess the impact that would have either been included in the research or not included in the research that they were extracting from with respect to the meta-analysis. But there are essentially predetermined measurement tools to assess these things. The statistical significance, so when somebody says there is no statistical significance, it means that when using statistical methods that either the sample is too small, or especially when you aggregate samples, you get a larger sample. So when you do a meta-analysis, it's much more likely you're going to be able to do some normalization to get to statistical significance. So the amount of change within these defined things, they're not seeing a change that would be notable that is better than random chance. It doesn't mean nothing happens. It means that it doesn't happen consistently enough to be a reliable pattern. Now, reliability being essentially a stable range of outcomes or a stable range of results from a particular thing, an interface, an intervention, interface or intervention, something along those lines. You can't trust that it's going to do it better than random chance. So it doesn't mean that it does absolutely nothing ever. It means that it doesn't do anything consistently that you can trust, that is better than random chance. For the non-musculoskeletal conditions, again, we get a very clear indication in the abstract of what they're looking at. The irritable bowel syndrome, so they would have been looking at qualitative measures, so patient-reported measures, as opposed to, say, observed measures, right? So the patient would report, in all likelihood, instead of a practitioner or a researcher observing. So we got IBS, we've got breast cancer, and very low weight preterm infants. So there is nothing qualitatively seen to improve in these conditions with respect to visceral osteopathy in a statistically significant way. Again, it doesn't mean nothing ever happens. It means nothing happens consistently more than random chance. Most of the studies were, to read this again, most of the studies were classified as high risk of bias, and the certainty of evidence downgraded to low or very low. So when you look at the things that would make other people trust the claims that you make, it's poor, right? The conclusion, this is in the abstract again to read, VO did not show any benefit in any musculoskeletal or non-musculoskeletal condition. So when you read that, you have to remember that this is based on clear inclusion and exclusion criteria. So you know that they're looking at neck pain, low back pain, urinary incontinence, irritable bowel syndrome, breast cancer, and very low weight preterm infants. So when they say that there is no benefit in any musculoskeletal condition, it should say any musculoskeletal condition that we were able to analyze, and then any non-musculoskeletal condition that we were able to analyze, because they didn't analyze them all. They analyzed specific ones. Those choices were probably built on what is available with respect to the research, as well as to some large degree what was pissing the researchers off. So they may have made those choices because those were specific things that were bothering them. Now, to turn back to the general arc of available research, what we want to consider is that when you see stuff about cranial osteopathy, visceral osteopathy, and their claims do not match their results. So when you actually analyze either how the research was done, it was done poorly with respect to trustworthy, reliable methods, or it is not doing what it says it's doing, generally speaking. So I'm not 100% sure how many systematic reviews, how many scoping reviews, how many meta-analyses, generally speaking, have to be done on the claims of osteopathy as they currently stand, and finding that the claims and the results don't match. I have no idea how many times we have to do this before we come to the conclusion that maybe it would be smart to adjust the methods, it would be smart to adjust the claims. We should go back to fundamental observational research, figure out what consistently occurs, choose a bunch of measurements, figure out what consistently occurs that is observable in patients when you use these approaches. And then once you figure it out, then you can go looking for mechanisms. First, you have to see what does happen before you even consider making a claim. You have to figure out what consistently, reliably, within a given range occurs before you can go looking for any mechanism of action. I think we claimed mechanisms of action based on very, very small pieces of data, aka one practitioner observing their responses in their practice. We didn't normalize this out enough. We didn't do this broadly enough. We didn't observe consistently enough. So based on the results of any meta-analysis in osteopathy showing, very generally speaking, that the claims of the systems have essentially no contact with observable reality, we should consider that relatively stable as a feature of the claims of these systems. When you look at other meta-analyses, you will see that things like return to work from low back injury or low back pain, things like reduction in hospital stays, there are positive results there, but those are more abstract results. They're less concrete, they're more observational. So when you go to a more generally observational research approach, osteopathy is showing something. Most people's personal experiences as practitioners or as patients would say that osteopathy is showing something. I think we just don't know what it's showing. So again, from this, I'm able to make the suggestion that we go back to fundamental observational research, see what consistently happens, then start thinking about why it's happening. We need to observe the fundamentals first. We need to get much more solid on the fundamentals before we start going into claims-based research, because everything we see with respect to the claims of the systems consistently says that the claims do not match observable reality. So again, we look through that paper, at least through the abstract, to come into the arc of systematic reviews of claims of osteopathy show that these subdivided systems, be it cranial, be it visceral, and probably others that just don't have enough research behind them to do a meta-analysis, their claims don't match observable reality. So if that's not an impetus to back up and say, we need to stop making these claims, we need to go to fundamental observational research, figure out what consistently happens, then go looking for mechanisms, and then go looking for what the consistent behaviors are, or describe the consistent behaviors. I don't know what else would be a good call to that. I think this is a strong call to stop the claims-based research, go back to the observational research, go back to the fundamentals, because I don't know that we're doing those well. And when we don't do those well, it makes it way easier to teach students from a cultural perspective. You teach what you were taught, instead of figuring out what the actual consistent behaviors are that give us the general positive range of results that we can see. My contention is that the barrier concept is the central concept. And as a really quick rough rule of thumb, don't make them say ouch. And what you're looking for is no abrupt responses or abrupt protective responses, and you could describe that as a pain response, to abrupt movements. So no faces indicating discomfort or an abrupt response, no sounds from the patient's mouth indicating an abrupt response, and no protective or quick contractions of soft tissues or pull away behavior from the patient. That's when you're doing the barrier concept right. Now, if we can get that concept stable as an educational delivery method, then we can start probably having more consistent results between practitioners, very broadly speaking, not specifically speaking, but very broadly speaking. We can sort of stabilize and start research from there. So these are the things that I am consistently saying. As if you listen to me, you can tell I'm very consistent in my message. So again, hopefully, if you listen this far, you're getting the idea that we would probably be well served to pull back to fundamental observational research instead of saying that we know how it works and this is the claim, and then consistently finding that the claims that we make as a profession don't match their observable reality. So thank you for listening. Hopefully you got something from that, and we'll talk again soon.